Thank you, Dr. Ritter, Dr. Campbell, and Sajids. It's an honor to be here. Our study is the routine versus selective use of upper gastrointestinal contrast series after omental patch repair for a gastric or duodenal perforation. My name is Stephanie Poris. I'm a general surgery PGY4 resident from Florida Hospital, Orlando. These are the co-authors listed on the study, and we have no financial relationships to disclose. Our study addressed the questions: does the use of routine versus selective contrast upper gastrointestinal series postoperatively adversely affect patient outcomes? There's currently no evidence-based guidelines on the routine or selective use of radiological imaging after omental patch repair for a gastric or duodenal perforation. Our study sought to identify whether a routine upper GI in the setting of an asymptomatic patient postoperatively would affect or lead to worse clinical outcomes. A review of the literature found no clear evidence for routine or selective use of an upper GI study. Surgeon preference and clinical appearance of a patient appeared to dictate its use. As many of you know, gastric and duodenal perforation are caused mainly by peptic ulcer disease. Outcomes and mortality can range anywhere from 10 to 40%. Options for repair based on the pathology at the time of diagnosis are non-operative management, gram patch or modified gram patch, resection and primary repair, exclusion and diversion, and endoluminal stenting. Listed here is a picture of a gram patch repair. As you can see, 3 sutures are placed through the duodenum and perforation and secured closed over a vascularized tongue of omentum. With gram patch repair, the benefits are it's intraoperatively easy and technically feasible laparoscopically. It's good in cases of intra-abdominal sepsis and hemodynamic instability. However, the drawbacks is it requires a good inflammatory response in a postoperative patient for adequate sealing of your perforation. Most studies of leak detection using an upper GI have been published in the Roux-en-Y gastric bypass literature. In 2016, Seti et al. Published in Surgical Endoscopy found that the sensitivity of an upper GI study to detect a leak was approximately 11% after sleeve gastrectomy. Other studies concluded missed leaks and even recommended abandoning the practice altogether. In our study, routine upper GI was performed in any asymptomatic patient after or before postoperative day 7. A selective upper GI study was performed on if one or more of the following occurred after postoperative day 3: a white blood cell count greater than 12,000, peritonitis, fever greater than 100.4 Fahrenheit, tachycardia greater than 100 beats per minute, upper GI performed after postoperative day 7. Our study was retrospective in nature from 2000 to 2016. We used approximately 115 patients age 18 and older. We divided this in any patient that had a gastric or duodenal perforation with omental patch repair. That group was divided into an upper GI and a non-upper GI group. Our upper GI group was further subdivided into a routine and selective group. We used a student t-test or Mann-Whitney U-test to report our means, standard deviations, median, and ranges. Categorical data was analyzed with a Fisher's exact test. A p less than 0.05 was considered statistically significant. We found no clinical significant difference in upper GI versus non-upper GI groups in relation to preoperative symptoms, postoperative symptoms, leak detection, reoperation within 2 weeks, and death. Significance was found, however, with a p less than 0.001 in length of hospital stay. We found a median of 15.5 days longer in the upper GI group compared to 8 days in our non-upper GI group. As you can see here, our subgroup analysis, selective and routine, showed no statistical significance when it came to gastric perforation, duodenal perforation, leak, reoperation, and death. There is no universal protocol currently for use of leak detection following omental patch repair of a gastric or duodenal perforation. There's currently no consensus on clinical indicators for ordering an upper GI series. Our study did not reveal any single trigger factor for ordering an upper GI series. Those patients who did receive an upper GI following an omental patch repair had an observed length of stay approximately 7.5 times longer than those who did not. The limitations to our study is that it is retrospective, low power, low occurrence of leaks, different surgeon experience, and an upper GI may have been a surrogate marker for an inherently sicker patient population. In conclusion, we were unable to demonstrate a benefit with the use of routine upper GI series following a omental patch repair of a gastric or duodenal perforation.
Okay, this is open for discussion. You commented a couple times on the extended stay. Did you find a particular surgeon that, say, decided that all these folks got an upper GI on post-op day 7 or post-op day 10? Was that a factor that played in to the longer stay, or did you identify something like, were there misinterpretations of leaks or concerning findings on the upper GIs that led to that increase?
Right, so our study did not focus primarily on identifying specific surgeons and their trends. We did cover approximately 7 campuses at Florida Hospital, so there was a multitude of surgeons going back for 16 years included in the study. However, I can't say it would, if it didn't fit the routine or selective group, it was surgeon preference. So.
I was just looking through here. Did you say, maybe I missed it, what percentage had laparoscopic and which percentage had open?
We did not specifically look at laparoscopic or open. It was just if they qualified and got an omental patch after a gram patch, after a gastric perforation or duodenal perforation.
So it could have been any
open or
any
laparoscopic
ratio, and so
yes,
then
sir.
there was issues related to that. So because obviously the patients that open surgery, we hope, have longer length of stay than laparoscopic because of the benefits of
Right,
that.
absolutely.
And was a standard technique in each of the hospitals for doing upper GI? Was there any variation in it?
None that we saw. However, we did not specifically categorize it out to the different hospitals.
Any incidents of aspiration in the patients who
No
had?
no significance, not one aspiration in our study. And we did look at that.
Okay.
Thank you.
Thank you very much.